external environment and putting it in your body, sort of. Whereas the digestive system, you're taking in the external environment and you're putting it within your body, but not at all really in your body. And so this is something that's really important to get as like a big picture concept with digestion, as opposed to with respiration. So when you're breathing, you're bringing the external environment into this cavity that we have in our chest, and we're swapping gas in there. It's a dangerous thing, and it comes up clinically a lot because the barrier between the external environment and the internal environment, internal being the actual blood that's running through the capillaries around the alveoli, that barrier is really, really little. And so things can get across it relatively easily, and you can damage it relatively easily. That's why your lungs are a really good way to deliver things to your blood, but it's also a really good way to deliver things to your blood that you don't want to have in your blood. And so it's fundamentally different in that way. What you put in your lungs gets into your blood without much of a barrier there. There isn't a separate organ built that filters out what the blood that runs through your lungs and maybe picks up tar and crap from the smoke in the air. There isn't an organ evolved to deal with that, because in evolution, we never evolved in a dirty air area. We didn't evolve smoking cigarettes. That's a new thing. Had we have evolved smoking cigarettes, we probably would have evolved a liver, something similar to a liver, that treated the blood that came out of our lungs. That's totally legitimate. Like, it could have happened that way, but it didn't. The air is pretty clean for the most part for the last couple million years. And so we don't have that. So the digestive system is actually way more built to deal with poisonous stuff. And so your lungs are a site of constant infection, it seems like, as you age. But your digestive system, yeah, it breaks apart a little bit, but it's got a crazy immune supply. Most of your immune system is sitting in your gastrointestinal tract, and you have an entire organ, your liver, that is meant to, even if something gets into your blood, it can help you deal with chemicals, and it can help you deal even with some pathogens that find a way across the lining in your digestive tract. And so that's how it's kind of fundamentally different, and that's why it's very, very different to smoke something than to eat something. It's really different. Because like with marijuana being legal now, this is something they've had to educate the public about, that it's not the same. When you breathe something in, it's going to hit you way faster, way more potent. And if you think about it pharmacokinetically, anything you breathe in, it spikes really quickly and then drops off because it gets right into your blood. But if you eat it, you're going to go through this whole long tube that we call the alimentary canal. It's got to go through your liver. It's going to get broken down a little bit by your liver, and it's going to slowly leak back out into your systemic circulation. So that's what's very different about taking drugs, taking both illicit drugs, any kind of drug, anything through your mouth, versus having it injected versus having you inhale it. There are different routes of entry, and the digestive tract is the slowest one. And that's why it's really hard to design drugs that you could just throw in your mouth and have them end up in your blood supply exactly how you want them to be. So it takes a lot of work to actually make that happen. So again, I mentioned the term alimentary canal. Alimentary canal. And so the alimentary canal, I just want to define that term because it's a weird term, but it's a term that's meant to point out that even though we're going to take this tube, the alimentary canal, just by definition, is this hollow tube that connects your mouth to your anus. And we tend to break this down into subcategories. Your esophagus, your stomach, your small intestine, which has 3 different subcategories within it, and then your large intestine, and then out in your anal canal, basically. We tend to break it down that way as if they're, and so by giving something different names, it tends to make you think they're really, really different. There are differences between those, but there are a lot of more similarities actually than there are differences. And so this alimentary canal is really in your curriculum to point out the similarities that exist between your esophagus, your stomach, your small intestine, and your large intestine. They all have the same basic layers of tissue from the inside. They're all surrounding an opening, right? The lumen in the center where your food is going to be. And they all have a mucosal lining that's exposed to that opening. And then just beneath your mucosa, you have what's called the lamina propria, which is actually mostly connective tissue, just anchoring the epithelial tissue to the rest of the alimentary canal. So that's a second layer in from the opening. So opening, or lumen, mucosal layer, lamina propria. And then the last one, which is really kind of difficult to see because it's relatively thin, is called the muscularis mucosae. And so it's actually smooth muscle that's in the mucosal layer that allows you to change the shape of your intestinal lining in your stomach with more precision than the external muscle layer that's really big and easy to see. And so those layers are going to be in every single thing we look at today that's part of the alimentary canal. Everybody's going to have, every section, the stomach, large intestine, small intestine, esophagus, they're all going to have those. But they're going to be in slightly different proportions. So in the stomach, there's an area called the muscularis externa, which is huge. It's really, really thick. In reality, it's like as thick as your pinky, but it's really, really big. But all of the alimentary canal has a muscularis externa. It's just much bigger in the stomach. And so it's important to know those layers, because as you read about them, and as I talk about them, I'm going to say, okay, you're going to find this, it's going to have a huge lamina propria. Or you're going to find these glands in the submucosa. Or look for the muscularis externa and notice how much bigger it is than anything else. And so these are just these general regions that everything in the alimentary canal has. And so from now on, we're going to talk with specifics, but don't forget that there are common features that unite the alimentary canal. And you're really looking at kind of the variation in those general layers that are found all the way from your mouth to your anus. So let's talk about digestion and define the difference between physical and chemical digestion. Physical digestion is mostly accomplished by your teeth. So this is actually mechanically breaking connections between tissues. And so when we're eating something, if you're eating meat, it's tissue very similar to us. And so you're breaking apart that connective tissue if it hasn't already been broken apart with cooking. You have to chew it up, make sure you're actually ripping apart and making these cells more accessible. When it comes to plants, a lot of times, like imagine eating corn or something like that, there's a lot of sugar inside of this little kernel of fiber. And that kernel, if you don't break it with your teeth, you won't get the sugar out. That's why it stays in your poop if it slips through and you don't chew it. Because that thing that's wrapped around is cellulose. Cellulose we can't break down. We don't have enzymes for that. So if you just eat corn and you don't have teeth, and you don't squish it with your gums or something like that, or maybe your tongue, it's going to go all the way through and come right out. And seeds are actually designed to do this. That's why they have the shells around them that we can't digest. They're meant to be eaten, and then we poop them out everywhere, and then boom, there's plants all over the place. And so that's like the idea behind seeds. And so that's why the coating can't be digested. So the way that we get nutrients out of things that actually aren't meant to be digested very easily is through that mechanical digestion. So it's really an important part. Cooking, the invention of cooking took that to a whole new level because we could actually sort of mechanically break things down using heat energy. And that made nutrients much more accessible to us than if we were to eat them raw. And then there's chemical digestion. So that's all the stuff you learn about in chemistry and in biology 112 when we talk about taking maybe glycogen in your muscles or in the muscles of something you're eating and actually breaking one large molecule down into smaller molecules. So we're doing chemistry here. We're not just changing the shape of things and ripping things apart. We're actually converting maybe glycogen into glucose or starch into glucose or something like that. And so this is going to take place beginning in your stomach. Not much of it goes on in your stomach, but most of it's going to go on in your duodenum. So the fancy chemistry is the chemical digestion. The brute force digestion is really the physical digestion, but both of them you need. Absorption, yeah, that's you actually taking it across the mucosal lining within the alimentary canal. Now, I was really general with that. I didn't say in the duodenum because it depends on what you're eating. If you're eating sugar, it can go right across the lining under your tongue or even on your tongue to some extent because sugar breaks down really quickly and can cross mucous membranes. It can be brought in. So for things like that, you actually can do it all over the place. You can bring in sugar anywhere where you have a permeable mucosal membrane. But for other things, you're only going to be able to absorb them in your small intestine. Mostly proteins and fats are that's the only place they're going to get into your body. So if you have issues in your small intestine, it's not going to affect, not necessarily going to get in the way of your ability to absorb simple sugars, but you won't be able to absorb proteins, and if you can't do that, you're in really, really bad shape. And then accessory digestive organs. So those are all the things we're going to talk about this week that are not part of the alimentary canal. So things like your salivary gland, your pancreas, your liver. Those are the main things we're going to be talking about. So things that are involved in digestion but aren't actually part of the big tube. They just dump stuff into the tube, or they treat stuff that comes out of that tube, that being the liver. All right, so the terms beyond that, the general histological plan, those are those subcategories I was talking about. So you've got the mucosa, which has those three layers within it. Then you've got the submucosa muscularis externa, and then that serosa term I mentioned last week, actually 2 weeks ago. It was in the trachea where you had adventitia around the outside. It was the most external connective tissue capsule around the trachea. It's the same thing in the alimentary canal. They just call it the serosa for some reason. Serous means slippery. It might be more slippery. It's the same idea. Your stomach, that muscularis externa, is not just exposed to the external environment. You wrap it in a tight sheet, and that is called the serosa in the digestive tract, but conceptually it's the same thing as the adventitia or the pericardium or any other connective tissue layer that just encapsulates an organ. And so that's why we have the visceral peritoneum and adventitia. In the esophagus is the only time they'll occasionally use that adventitia term. But for our purposes, really it's visceral peritoneum. So that's the only term I'm really concerned with you knowing. We already talked about the most commonly used term for adventitia, which is in the respiratory system. But visceral peritoneum, for some reason they don't have parietal, but I'll bring up a picture in a second. We already know what visceral and parietal mean. Visceral is always going to be the deep layer of any kind of connective tissue capsule. And so that's what when we get to looking at the mesenteries, we'll bring this up again. But it's just like visceral and parietal pericardium. Visceral meaning deep, parietal meaning on the sides of. But I'll bring up a picture of that in a moment. All right, let's look at the oral cavity though. Oral cavity is kind of cool. This is something we're familiar with. You've looked in your own oral cavity. Thank goodness for mirrors. This would be like crazy news if we didn't have mirrors, right? We would have only looked in other people's mouths. But our mouth is pretty familiar to us. We have a whole section later on in the packet talking about teeth. For the most part, I'm going to let you guys work on that on your own. A lot of this stuff is pretty familiar, like the different types of teeth. But there's a couple things like the dental formula I will talk about when it comes to teeth. But what I want to focus on here is just this oral cavity component. So we already talked about the pharynx. There's some repetitive terms in this sheet that are just straight off of the sheet from last week. Nothing new. There's tonsils on the sheet too. You guys have already learned that stuff, so I still want you to know it, but it's not new. It's all the same stuff we've talked about. Here's the new stuff though, because remember the nose was the respiratory system. With our mouth, even though we can breathe out of it, it's really for the mechanical digestion. So you got a bunch of teeth in there. But more interestingly, and maybe a little bit more foreign, most people know about the uvula, that little thing in the back that hangs down and can flap backwards so that when you're swallowing something, it's less likely to go up into your nose. It doesn't work perfectly. Some people have voluntary control over their uvula. They actually can control the muscles in the back of their mouth enough to just close it off and open it up, and it'll change how they sound. Cool. And then there's some terms that in your book are different than what's on your sheet, and it's just flipping the prefix and the suffix of the term. Let me pull it up here. So 11 and 12, pharyngopalatine arch, and on your sheet it's palatopharyngeal arch. Don't care, you can say it either way. Just understand the parts of the word and it'll tell you a little something about it. Basically there are two big arches in the back of your mouth. One of them is closer to your tongue, one of them is closer to your pharynx. The glossopalatine arch is this arch right here. It connects to your uvula actually. So if you say ah, look in the mirror, you'll see an arch connecting really the uvula to the sides of your mouth. And that is more anterior or closer to your tongue, so it's glossopalatine. And then the pharyngopalatine is just behind it. It's a very similar size, but it's just posterior, closer to your pharynx. Both of those have muscles within them that help us in initiating swallowing, because these are all voluntary muscles that are behind this tissue. So we initiate swallowing voluntarily. These are also muscles that you can control in speech, and you learn to control them when you're learning to talk. It changes the pitch of your mouth, of your speech. By you changing the shape of the back of your mouth, you can actually change how you sound. So those are the two arches, a little bit foreign, so I wanted to point those out. There's tonsils listed in there. I already talked about the mylohyoid muscles, so that is important in controlling the depth of the bottom of your mouth, which also can change your speech, but is more important when it comes to chewing. We have a lingual frenulum. Frenulum is a fun word. What this is, we have a lingual frenulum down here under the tongue, and we also have labial frenula here and here. So you can feel the labial, and some of you have enough tongue dexterity. You can actually feel the lingual frenulum, but this is just a connection that's right down the axis of symmetry of your body that helps your lips stay anchored in the center and your tongue stay anchored as well.
The singular is just an A at the end?
Yes. No, frenulum is the singular.
Okay.
Frenula is the plural. And then the last part is just our salivary glands, parotid, submandibular, and sublingual. So two of these have really good names, so they tell you where to find them. Submandibular, you can feel under your mandible. Right around here, on me, it's about the size of an almond, just right under both sides of your mandibles. Then your parotid gland, you can feel, but you can't distinguish it very easily from your masseter unless it's inflamed or you have some kind of cool growth in it or something like that. But it's sitting right on top of your masseter. This one we're used to because we feel this, right? When you bite into a lemon or drink a margarita or something like that, right? Something really sour, they're going to contract. And they have not skeletal muscle. It's not the masseter muscle that contracts. It's the myoendothelial cells that are actually around the gland. And so myoendothelial are like a hybrid tissue that's kind of like skeletal muscle, kind of like endothelium. But it basically contracts, and you can physically feel that, and that squirts a bunch of really watery fluid into your mouth. So one thing to know about the parotid glands functionally is that the parotid gland is the main one that's responsible for hydrating the food that you eat. Because we can't absorb anything unless it's dissolved in water, number one. We have to have it dissolved in water by the time it gets down to the stomach and the small intestine. But also, it's just really hard to swallow dry things, right? Has anybody tried to eat 6 crackers or whatever, the saltine challenge? It's really hard to do. You almost can't do it or you'll choke, and kind of do it. But basically, 6 saltine crackers, that exceeds your parotid gland's ability to saturate things. So that kind of gives you some idea, wow, we really would be kind of screwed if we didn't have these parotid glands, because we'd have constant dry mouth, and more importantly, we wouldn't be able to eat things if they were too dry. We'd have to wait forever for there to be enough saliva dissolved, or we'd have to put it in the water and then eat it like they do in the food competitions, and that's why they do that, because they could never eat 55 buns in that amount of time. Their parotid gland couldn't keep up. So that's the hydration part. The other two, submandibular and sublingual, are mostly mucus secreting. There's some water that comes out of those two. It's not just pure fat coming out of it, but it's mucus. And what mucus is doing is not hydrating, it is lubricating. And so you need things to be wet and slippery for them to smoothly go down your throat. And so I encourage you to eat 6 saltines in a minute. I think it's a minute. You'll notice that challenge. And then the other thing is egg yolks, hard-boiled egg yolks. They kind of invade your ability to both hydrate and lubricate. And so you can sort of choke on egg yolks. They'll break down eventually, but you can have a scary moment if you already had a dry mouth and all you did was eat an egg yolk. But it is really hard. Egg yolks are really cool because they emulsify. They're really cool in cooking because they do stuff that nothing else will do. But when you hard boil them, they dehydrate, and then they're very oily too, but they're dried oil. So when you put them in, you can't even really lubricate them, and they don't hydrate well. And so you need to drink water with them if for some reason you're eating just yolks. All right, and then location sublingual, again, I didn't mention this, but it's below your tongue. You can't really feel it very easily. But we do have them on the models in the back, so check those out. And then as far as histology, as you can see, I crossed that out. We're not going to do any histology of the oral cavity. The last thing I want to talk about before I get away from this image is the raphe. And the hard and soft palate we've already talked about. Hard palate, palatine bone and maxillary bone. It's bony, you can feel it with your tongue. And then you go back further, you have the soft palate, which is just fleshy. But on the hard palate, you've got these ridges on top. And these ridges are actually really, really important because what they do is your tongue is really cool. It has incredible dexterity. It's actually quite strong too. It's skeletal muscle, so you have voluntary control over it. But when you go to eat something, it's like trying to manipulate something with one finger. You need something to oppose it, to grab things and really control things, and you don't have that. You don't have a hand in your mouth. That would be way easier. You just pull it right down. but you don't. You have to use your tongue to press things up against either the sides of your teeth, or usually what you do is press it up against the roof of your mouth, because those raphe are actually the ridges and they give you traction. And so when those are there, when you have this wet, slippery food, you could still grip it and manipulate it and then accurately, or maybe in a coordinated way, swallow things. Because if it were slippery, if it were just like the inside of your cheeks, you'd maybe press it up against the roof of your mouth and it'd slip down into your trachea and you'd choke. And so this is a really, really important feature. So like for retainers, they usually don't make them just slippery on the top. Because if there's a chance you're going to eat anything, you better have some amount of traction in the material that goes on the roof of your mouth, because you're likely to choke on something if you don't have any traction up there. Dogs have huge ridges, huge raphe, because they don't even have thumbs. And so they're trying to do everything with their head, and so it's really, really essential for them to be able to have that traction on the roof of their mouth. All right, so here's a close-up of teeth again. I'm going to let you guys move through this. It's later on in the packet. Let's just talk about the dental formula while I'm here. There's just one paragraph in your paper. Let me just explain to you what it means and what the normal human dental formula is. So different types of teeth. There's 4 different kinds. Incisors, canines, premolars, and molars. And so let me just pull up the draw on this mouth. So the dental formula you're just going to see written potentially in someone's patient records. And so you could just count up all the teeth that a person has and give a really long numerical definition or write a paragraph about it. But for medical records and documenting things, brevity is everything. And so what they basically do is they say, okay, we know the normal plan for humans' teeth. There's not much variation. For the last set of molars, there's a little variation. But for the most part, humans, they're all symmetrical, left to right, initially. Now, you could have lost a tooth, and you'd reflect that in the dental formula. But the way this formula is thought of, let me just write the formula so you guys can see what the heck I'm talking about. So 2, 1, 2, 3 is the most basic formula, and it's usually documented as, again, if their mouth is symmetrical, as 2, 1, 2, 3 over 2, 1, 2, 3. And the reason is there are 2 incisors on one side of one half of your mouth. One, a little wide there on the bracket, 1 canine, 2 premolars, and 3 molars if your wisdom teeth are present, all of them. And so that's where the numbers come from. So you could do a formula that represents the whole thing, because really, you have 4 times this many teeth if you're totally symmetrical. But what this is basically showing is you could just report 2, 1, 2, 3, and the assumption would be that you have the very normal human, dental formula. But if the bottom of your mouth were different than the top of your mouth, you could change it. So say you lost one of your wisdom teeth didn't come in, it would look like this. So just a numerical way to represent a difference in teeth, and it's highly simplified for brevity. And so you're going to potentially see a little bit of variation based on the teeth back here, but usually not. Some people will have a 4th one, depending on how big their mouth is. But that's all the dental formula really is. I don't know how often it'll necessarily come up. It'll depend on what field you work in. Yeah.
But so if you had differences more than, if, one side, how does that?
So then you would write it again. You would basically have 4 boxes. It's dividing your mouth into quadrants. And as long as there's symmetry there, as long as it's like a mirror image on either side of your mouth, you can leave off 1/2 just for simplicity's sake. But if there is a difference, then you have to include it. So someone who was missing a tooth from every quadrant and it was a different tooth, you would have 4 separate numbers to represent it. But hopefully that's not the case.
They would all be fractions like that?
They would be 2 separate fractions divided by left and right. Okay. Top of the fractions, top of the mouth, bottom of the fractions, bottom of the mouth. Yeah?
Is the wisdom difference complete?
It is. So the third one, so this person would have, this would be all 3. So wisdom teeth came in from the top, but were removed from the bottom. So this would be me if my top ones came in, but they haven't. But my bottom ones are gone, so I'll never have a 3 there. But this one, maybe. They might still come in. Who knows? All right, so these are just the words to go along with those individual layers that I talked about at the beginning. So let's talk about the esophagus. This is our first section that histologically we're going to be looking at. It's pretty straightforward, but it's kind of an interesting organ because it's both voluntary and involuntary, and it's incredibly important because if your esophagus doesn't function, then you're not going to be able to take the mechanically digested food and get it into your stomach. And that's a huge issue. And if it really doesn't function, then you can't drink water, and that's an exponentially larger issue than not being able to eat. So top third, roughly, of your esophagus is voluntary. So the beginning of eating is voluntary. We choose to swallow. It's about 1/3, but there's some overlap in here. So as you proceed down beyond the 1/3 of your esophagus, you get into an area where it's actually a mix of both smooth and skeletal muscle. So this is about the last, if you ate something you didn't want to eat, and you're trying to get it out real quick, before it goes down any further, you're going to lose control of it here, and you're going to swallow it whether you want to or not. It's going to hit your stomach, and then if your stomach doesn't like it, you're going to vomit it out. And that's a passive process. And so that's kind of interesting when you look under a microscope. You may see some skeletal muscle surrounding this portion of the alimentary canal because this is the only portion that you have significant voluntary control over. But lower part, you do not. So if we look at this, it's a pretty simple tube because there's no absorption going on here. This is just a transport tube. Things spend very little time in your esophagus. It's kind of crazy how quickly things get from your mouth. It's well less than a second. It depends on what you're eating. But what we have here is a huge muscularis externa, multiple layers. If you zoom in closely and you see striations, then you're looking at skeletal muscle. If you zoom in closely and you don't, and it's generally a little bit more circular appearance of the muscle when it's the smooth muscle. But it just depends on where the slide is taken. But either way, it's called the muscularis externa. And then you've got your pretty thick mucosal layer, which is made of stratified squamous epithelium, which is really the distinguishing feature of this tissue, because there's nothing else that we're going to look at this week that has stratified squamous epithelium. But it should make some sense. This is still where the stuff you're eating could damage you, like physically, because it could be sharp still. You know, you've done your best to moisturize it and everything, but this esophagus might get scraped a little bit. And so remember, wherever something might have some abrasion, you're going to have stratified squamous epithelium. And then you can see a pretty thick lamina propria right here, which again is the layer, still part of the mucosa, but it's just beneath the epithelial layer. And in this case, there's not a whole lot going on there. There's a decent amount of blood. And so if you do have something damaged the esophagus significantly enough, you will have bleeding into the gastrointestinal tract, and so you'll have bloody stools from that. And that does happen as we age. This division between the stratified squamous epithelium doesn't have as good of integrity. Our salivary glands don't work as well. We're not as good at swallowing, and so a little bit of bleeding in the esophagus does happen occasionally. There's a little zoom in, just a reminder that when you're looking to classify something that's epithelial tissue and it's stratified, you only look at the top of it in order to classify it. So even if the cells look, pretty much almost circular or sometimes even a little cuboidal down here, it doesn't matter what it looks like down here. It's only what it looks like at the top. That's always how we classify it. And it's non-keratinized. Our skin is keratinized stratified squamous epithelium. This is non-keratinized because if you remember, keratin is just dead squamous cells. This would be keratinized, but this is a moist environment that you're hopefully eating and drinking through a lot. So any dead cell on the top, you just eat it, basically break it down, and it's all good. Another shot there. All right, let's talk about our different membranes. So again, this is this visceral and parietal concept again. So everything from the stomach down is covered in has a very similar strategy to reduce friction. It has a visceral layer that covers the outside of the actual organs themselves, so stuck to the organ. It has a parietal layer that covers the inside of the abdominal cavity. So just like our parietal pleura covered the inside of the thoracic cavity, this covers the inside of the abdominal cavity, but it's not continuous with the pleura or anything like that. They're very separate, separated by the diaphragm. Now, we also have the mesentery. So we'll see a picture of this in a second, but the mesentery connects the small intestine. It's what anchors the small intestine to the back of your abdominal cavity. It's what your small intestine kind of hangs off of your spine a little bit, and you'll see in a second that the mesentery is the actual physical connection between the two. And then the omenta, or the greater and lesser omentum, that's fat. That's intra-abdominal fat. So this is fat that you would not see in a person directly. Like we think of fat as the subcutaneous fat, so you can see it under the skin, you can notice, you're like, oh, I'm getting a little fat. You're not really gonna see this. This is it's under the muscles of your abdomen. So you may actually have a larger circumference of your abdomen, but you won't visually see it under the skin. You could have an increase in intra-abdominal fat in the form of larger, greater, and lesser omentum, but you can still have a rock-hard six-pack. So here is the mesentery view. This is a nice view. It's a mid-sagittal section. And you can see, it's really, especially even when you're looking in cadavers, it's hard to figure out what the heck is connecting the small intestine to the rest of your body, because when you first look at it, it looks just like you did a really bad job packing or something like that. Like nothing's that organized, it's a tube that's all mixed up, but there is a physical anchor, which is really important, called that mesentery. So notice that basically everything that's in sort of this fleshy color here is all a continuous sheet that all bunches up together and anchors to the back of your abdominal cavity, and its force is transmitted to your spinal column in the lumbar region, which is a good thing because that's a really nice place to hang stuff from. So like if I jump up and come down, for a second there my organs were floating a little bit, and then as they hit the ground they don't fall and get smushed down that much. They do sort of slam back a little bit, but they're anchored more or less in place by the mesentery. Very similar to the mesentery is the mesocolon, and that's what anchors most of your large intestine to a more superior place, but also on the back of the abdominal wall. And so these are really important. If you lose connections here, or you have laxity in these areas, your organs can actually get twisted. And so some people have really nasty disorders, nasty in terms of what they have to experience, in that their large intestine can actually get knotted or twisted, and food can't move through. It's incredibly painful, and surgery is not particularly useful in solving it because you can unwind it, but then you create so much scar tissue that you end up having usually a lifelong kind of battle with that. So it's really good to have these in place. They also have a little bit of a proprioceptive function. So if you ever jump off something high and you get that like stomach feeling, it's actually your organs floating for a significant amount of time, and floating not in water, but like, you know, zero gravity when you're falling. And that you can actually sense that, and it's very uncomfortable. And so that's where that comes from. It also prevents your organs from sagging down, because over time as we walk around, they would all just fall to the bottom and everything would be in your pelvic cavity. So that's mesocolon and mesentery. Both have a similar beginning. Mesentery is small intestine, mesocolon is large intestine. So here's a little bit more realistic view of large intestine and small intestine. And there you can see mesentery, mesocolon, and then it's got the greater omentum, which really is like a sheet hanging down over about everything from here down. It just drapes over the front. And the omentum, it's really well vascularized. Fat is somewhat well vascularized, general fat like subcutaneous fat, but omenta is really well vascularized. So it's very different. It must be, there's not a whole lot known. They're just learning about fat metabolism and stuff like that, and the different roles that fat plays. It is an endocrine organ. Like, I'll get on my soapbox about how every organ is actually an endocrine organ, but fat is definitely an endocrine organ. It releases leptin, which suppresses hunger, and it probably does some other stuff. But it seems like this would be the most important type of fat because it's directly connected to your digestive system, and so it likely plays a more significant role that I imagine we'll learn about more in the future. But it's really variable. Some people have a lot of this in terms of just mass, some people don't. There's a real picture. So you can see how thin the mesentery is. And you can see that really nice blood supply leading from the small intestine to the liver. So that blood right there is toxic blood, basically. If that blood were to bypass from that organ to your direct blood supply, you would probably have major issues. So here's the omentum with it draped down. So it is connected to the what's called the greater curvature of the stomach, which is, the stomach is sort of a C shape. So it's this outside ridge here. There's a lesser omentum that's on the lesser curvature, which isn't illustrated here, but it would be a second flap that's much smaller. But it's this greater omentum that gets all the press because it's very obvious. It's huge, but also very, like I said, really variable. This is really good for abdominal cushioning too. So like football players that have an exposed abdominal region usually, they're actually really concerned that they keep their body fat up to a certain level. And they're concerned mostly with this fat. They don't really care how much fat they have under their skin. They're more concerned with making sure they don't have intra-abdominal damage. And this is a good way to protect your organ. All right, let's look in more detail at the stomach. So we've already looked at the esophagus. We've looked at kind of an overview of the digestive system and some of the interesting connective tissue and fat. But your stomach is, I think, the most unique region of the alimentary canal because it deviates from the tube design the most. It is sort of a tube, but it can expand greatly. And that's really kind of obviously important why you'd want to be able to have your stomach expand. The bigger your stomach is, the less frequently you have to eat. You can just eat something huge and then hang out and not have to worry about eating for a while. And so it's different organisms that, well, an anaconda or something like, or a boa constrictor is a great example of one extreme. So they, for like half the year, they barely even have a stomach, and then they have a hormone that's released that says, oh crap, you need to eat. You're running out of fuel. And they actually just hypertrophy this massive stomach and then go out and look to strangle things. And that's what they do. And they strangle it until it's kind of dead, and then they eat it. Sometimes they kill it, sometimes they don't. In Florida recently, there was an anaconda, no, it wasn't an anaconda, it was a boa constrictor, which is really invasive in Florida. It ate an alligator and broke the alligator's back, but didn't kill it. And the alligator ate through it, killed the snake, but then the alligator died. So it was a really sad outcome for both. But snakes have a monstrous stomach is the point. And so they, if that would have worked out better for the boa constrictor, probably would have been good for like a year. And so we don't do that. We've always, really recently in evolution, been able to find food pretty frequently. So our stomach isn't that impressive, but it can stretch. It stretches not because of its inherent elasticity, though it does have some. It's because it has wrinkles in it. It's all shrunken up and ready to expand. Those wrinkles are called rugae. They are not for surface area. We're going to see a lot of wrinkles in the rest of the alimentary canal. It's not what they're for. You're not doing much absorption in the stomach, so you don't need the surface area. What you need is it to just be able to expand. And that's what those rugae are. They go away when your stomach's really full. Stomach also has a ton of muscles. I don't think you have, I think I crossed the 3 muscles out histologically. But you will see maybe something that will also help you pick out the stomach is how much muscle it has. It's your most muscular organ in the alimentary canal. Yeah.
Just so I can wrap my head around that concept a little bit better. So you know how there's like levels of fullness? And how like you eat and you're like, oh, I feel pretty good.
Oh, yeah.
But then like you can eat to like where you have to unbutton your pants and
you
like
can't breathe
rest.
anymore?
Yeah. So
Yeah.
is that just like, so that's full dewrinklage, right?
Oh,
and
yeah.
then like
Yeah.
partial dewrinklage is when you're like, oh, I feel
Totally.
full, but I could walk around, I can move.
So take a look at where your stomach is, and you'll understand some of the negative consequences of buffets. I'm horrible at this. I totally overeat. But for me, I don't usually have to unbutton my pants. I just
That's
can't.
like Thanksgiving.
I just can't breathe anymore. That's my problem. My vital capacity just goes through the floor because the liver isn't going to move. Liver's a solid organ. Stomach, when it expands, it will push down, so that would transfer force down here, and you need to unbutton your pants. But for me, I don't ever feel a need to unbutton my pants. I just like, I can't breathe anymore because I'm pushing up on my diaphragm. And so it like actually hurts a little. And I hope it's my diaphragm, not my stomach. But that's where it does. Our stomach does change size significantly, and it will usually push on both the diaphragm and your internal organs below it. But the diaphragm, you should try measuring your tidal volume before and after you go to like an Indian buffet or something like that. All right, so again, three layers of muscle here, 2 layers of muscle in most of the alimentary canal. Normally you have a layer of muscle that is going to go like around the alimentary canal. You know, it's a tube. And normally you have muscle that encircles it so you can pinch off the tube. And then you have another layer that also goes longitudinally so that you can shorten the tube. That's the normal situation in the alimentary canal. Stomach, because of its shape, it has a third layer, a third oblique layer that allows you to sort of move food. It's like a compost bin. You need to rotate it occasionally. It's kind of what your stomach does. It can actually flip the food over. Basically, denaturing proteins is the big idea in this area. You want to break those proteins down, not necessarily into individual amino acids, but you want them unfolded so that you can easily digest them once they get pushed onto the small intestine, which is right down here. Other features, it's got a fundus at the top. A lot of your slides will say fundic region. Just means it's the top of the stomach up here. You have the cardiac region of the stomach. It is close to your heart. It's also called the gastroesophageal junction right here. There is a valve there that is very important for preventing food from going back up the esophagus when your stomach contracts a little. And you've felt your stomach contract before. It happens. After you eat something, especially if it's something you don't like that much, it will, like your stomach doesn't like, you might like it, but your stomach might not like it so much, and it will physically contract. But that esophageal junction, that sphincter there, often referred to as the cardiac sphincter, needs to keep closed so that you don't have acid reflux. The more you eat, the more likely you are to have acid reflux. There's higher pressures in your stomach when it's really, really full. Also, the shorter you are, the more likely you are to have it make it up really far. And so, because you just don't have, it doesn't have to go very far. And the more frequently you overeat, the more likely you are to have it too. The idea, I think, is that you overstretch that valve. I don't know though. I've pushed that limit a little bit. We'll see. I've never had heartburn though. Someday. So here's another picture of the position of the stomach. And we'll get into the histology next. This is probably the most detailed histology of this week. Mostly because you have a collection of 3 cells that I'm going to want you to pick out that are within the mucosa of the stomach. And so the mucosa is really thick in the stomach. That's one way that you can pick it out. If you're zoomed out enough, you'll see the rugae themselves also as a distinguishing feature. But let me show you a little bit closer picture of what are called mucous neck cells, or sometimes referred to as mucus cells of the stomach. So there are these ones right up here. The next one. This is a little bit better. I'll go back to the previous picture in a second to look at the other cells. But if we're starting from the lumen and working out, you've got mucus cells. You know they're mucus cells because of how light they are. They don't stain well at all. The mucus doesn't pick up the stain very well. So this is the lining of your stomach. So if you're like vomiting up the lining of your stomach, it's the mucus cells. Mucus cells they're not flat straight across. They have these little pits. And these are called gastric pits. You can see them over here. Those gastric pits, if you were to go down into them, which is not the normal way things happen, but if you were to go down into them, they would lead you to a region called the gastric glands. And those gastric glands are full of a couple different kinds of cells. The 2 that I'm going to want you to pick up are called parietals. One of them is called parietal cells. The other one's called chief cells. So parietal cells and chief cells are different in that they secrete different things. So parietal cells secrete hydrochloric acid. That's the only thing I really want you to know. And chief cells secrete pepsinogen. Those are the main two things I want you to know, because there's a relationship between these two things that you may have already talked about in lecture. But pepsinogen is actually an enzyme that breaks down proteins. Now, it's released from cells in the gastric glands, and you're mostly made of protein, and so it's kind of a dangerous game to be releasing these enzymes into these gastric glands and hoping that that enzyme doesn't break down your own stomach. And it generally doesn't, because hydrochloric acid is secreted up higher in the gland from the parietal cells. And the pepsinogen doesn't work unless it's in an acidic environment. And so once the HCl migrates up into the stomach, it kind of pours out of those gastric pits. Kind of erupts out like a very low pressure geyser coming out of the bottom of the stomach. The pepsinogen will follow and be activated and turned it into pepsin, which will then break down proteins. So the moral of the story being, it's fine to make enzymes that break down protein as long as they don't work when they're actually inside of your living tissue. When they're just inside of the stomach, they will break down the mucus cells. They'll totally do that. But the mucus cells are just replenished. Question?
So the acid turns the pepsinogen into pepsin.
Yeah, it activates it. So it's basically an enzyme that's actually denatured at normal human pH. And it doesn't go back to normal until you put it in a pH of about 2.5. So it's a way to use acid to sort of regulate enzymes. And then when you pass it into the duodenum, it also turns off, because the duodenum is a little bit basic actually in its pH. But either way, pepsin only works in the lumen of the stomach. Pepsinogen is only activated in the lumen of the stomach. Occasionally, if you have something that hurts your stomach lining, bacteria, there's H. pylori bacteria that we all have in our stomach. For some people, whatever reason, it bores through this and starts to expose, without the protection of mucous neck cells, it starts to expose the stomach's mucosal lining to the acid, so that when the chief cells release pepsinogen, it's actually activated down here, and you'll start to eat through your lining of your stomach. That's how those bacteria really cause a problem. The third one, or fourth cell that I left off is the enteroendocrine cell. They're really difficult to identify on any of our slides, but they have an endocrine function because the stomach, like every organ in the body, in my opinion, is also an endocrine organ. It communicates and tells the pancreas what to do by releasing hormones into the blood. And so there's an endocrine function of the stomach as well, and that's what those enteroendocrine cells do. That's just FYI, I'm not going to ask you about that. So in terms of picking out parietal cell versus chief cell, the key, I'll just tell you that it's really straightforward actually. They have different colors. Parietal cells secrete hydrochloric acid, and things that are acidic stain pink. Chief cells secrete a relative to the acidic hydrochloric acid, it's a little bit more basic, so they're the purple spots that you see. And so all you're really doing is orienting yourself within the stomach via the microscope, and you're going to find the apical border, and you're going to come down from that, and then you're going to see a whole mess of cells. Basically, the bluish purple ones are your chief cells, and the pink ones are your parietal cells. And physically they do look a little bit different. The chief cells are a little bit smaller cells, less cytoplasm. The parietal cells look really like a fried egg that has pink egg white. But that's pretty much it in picking out those cells. But I do want to let you guys know how I'm going to ask you about this stuff is a little bit, we'll make it a little bit easier on you. So I'm going to give you two different types of scenarios at the microscope next week. I'm either going to give you an organ that you don't know what it is, and I'm going to ask you to identify the organ. So you can use the distinguishing features I've been talking about and will continue to talk about, or you can figure out some other way that you'll know that you're looking at the small intestine, or you're looking at the colon, or you're looking at the stomach. So that's one scenario. You're just identifying the organ. That's it. So you can move around, you can look around, and just try to figure it out. The second scenario, I'm going to tell you the organ, and you need to pick out the cell type. So that's way easier because half of the logic has been done for you, but it's much more realistic. You're never going to, in the future, usually not know what kind of tissue you're looking at. You're going to have one or two situations come your way. You're going to know that, oh, this is a biopsy of this tissue. Find these cells. So somebody's going to tell you the tissue and you're going to find the cells, which is one scenario on our exams. And then the other one is you're going to have an unknown tissue And you're going to try to figure out what the heck you're looking at. And that's what the other scenario is you're not picking out individual cells. I'm just going to ask you what organ you're in. And so those are the two ways that it's going to come. And so hopefully that emphasizes you guys categorizing where cells are found, because that way if you see something like this and it's covered up, it doesn't say stomach, and I ask you for a cell, you know you basically have a 1 in 3 chance of getting it right. And so that will reward you for being able to deduce your way to the answer rather than trying to have photographic memory, because that doesn't work that well. Here's a little close-up. So you can see the cells really do look different besides the color. But the key thing that your eye is going to pick out is going to be the color difference. All right, small intestine. So there's 3 regions of the small intestine. Why are we on the pancreas? Hold on, let's go here. Small intestine, so it actually has 3 regions. The first region is the duodenum. That's where you're going to spend most of your time in lecture. And even clinically, most things go on in the duodenum. That's where all the fancy stuff happens. That's where protein digestion, most of it happens. That's where if someone has an inflammatory disease that causes scar tissue to form in the small intestine, you're really concerned about it if it's the duodenum, because so much goes on there. The duodenum is relatively small, about 20 centimeters, so really small compared to your 20 plus foot of small intestines. The remainder of the small intestine is about evenly divided into the jejunum first, so it goes duodenum, then jejunum, then ileum. And the ileum then empties into the large intestine. And so as far as picking out the organ, I'm going to expect you guys to be able to pick out, if I give you an unknown slide to look at, there's one of 2 things. If you think you're in the small intestine, but you think you're in the duodenum, I want you to put duodenum. I want you to be specific with duodenum because it's such an important part. If you're in you have a slide of a small intestine and you're like, darn, I'm pretty sure I'm not in the duodenum, and we'll talk about how to know this in a second, then it's okay to just leave it as small intestine. I do not expect you to differentiate jejunum and ileum from duodenum at all. So basically one of 2 different things. It's either the duodenum or it's the small intestine. You could write ileum/jejunum if you want. But I don't care that you distinguish those 2. I do care that you pick out duodenum for the organs for the small intestine. And in terms of identifying this on models, because our organs aren't stretched out and easy to measure with a tape measure how long each one is, you should know you're in the duodenum because it's the beginning. And on our models, it's cross-section and right next to the stomach, and the pancreas empties into it, so it's very clear that that's the duodenum. And then for the ileum, it's pretty clear that it's the ileum as long as you're down here, because it's the only thing that empties into the large intestine. But I'm not going to ask you about the jejunum on a model, because we don't have a way to really know where it is. You could guess, but I'll ask you only on the models to identify duodenum and the ileum. And it'll be at their most extremes.
On this picture here, you see the word duodenum.
Hmm?
Is that pretty much it right there? Or
It's basically right here, in proportion to this drawing, from here to here. And then it would go on for another 10 feet or so of jejunum and another 10 feet or so of ileum. All right, so if we look at the small intestine, all of the small intestine looks pretty similar. There's some distinguishing features that distinguish one from another. But all of them have what are called plicae circulares, and they don't have rugae. So that's one way to contrast them to the stomach, is that these kind of look like rugae, but they're much skinnier. Rugae, the entire organ would fold in because they're really just wrinkles. These aren't wrinkles. They're not for stretching. They're for surface area in this case. Since this is where you're doing the majority of your absorption, more surface area means I can digest and extract more calories. Because with your digestive system, it kind of moves through at a set rate, and the tissue of the small intestine, its job is just to grab as much as possible. So the more surface area, the more things you can grab, the more calories you can take in, and the better off you are. So like the snake example, the snakes basically close down their small intestine for most of the year, and then they upregulate when they're in feeding mode, basically. And this just grows and grows and grows, and they get this massive surface area so that they can actually digest you know, a whole alligator or something like that. It takes a while, but they will be able to pull it off because they have such hypertrophy of this tissue. So plicae circularis in 3 dimensions, you'll appreciate a little bit more of this structure. All for surface area, not for stretching. You should not be stretching your duodenum or your jejunum or your ileum. Coming off of each one of those plica are villi, as it's labeled here. So these are these finger-like projections, also for more surface area. So just imagine how much more surface area you get out of this by having not only the plicae, but the villi coming off of them. And there are even microvilli on top of the villi. So you get this amazing amount of surface area. So in a 20 centimeter area, you can absorb quite a bit of proteins and fats. And so inflammatory diseases, like I mentioned before, if they happen to happen inside of the small intestine, which does happen because you do have a lot of your immune system cells here, and if they launch an attack that's really vigorous, they may damage the tissue in the process. And if you have scar tissue here, you're not going to be able to absorb things as efficiently. And so scar tissue formation in the small intestine is a really serious thing, because if there's enough of it, you won't be able to absorb enough protein. So here's a closer look at the villi. The villi themselves as a structure, they're not just, you know, epithelial tissue or absorptive cells around the outside. There's some goblet cells mixed in here. And then there's simple columnar epithelium surrounding it. But in the center, you've got blood. So you've actually got arterial and venous capillary beds coming through here. And then down the center, you have nervous tissue. So you have nerves in here. So you can actually have some feedback as to what's going on in your mucosal lining. And then you also have what are called lacteals. And these are just lymphatic vessels. And they're really important because lymphatic vessels are primarily how you get fats into your body. And they are the back door for things to get into your blood supply that are not that don't need to go through the liver. So you remember that cisternae chyli, like the one structure I wanted you guys to know in the lymphatic system? It was like right here on the back of the spinal cord. Huge thing. That's taking in the fluid that's been absorbed by the lacteals, and it does it before it gets to the liver. So if you want to sneak something into your blood, and you shouldn't do this, but if you wanted to sneak something into your blood and bypass the liver, the best thing to do is to have something that is either fat-based, like a fat-soluble vitamin or something like that, or something like alcohol that's a molecule that actually dissolves in both, but will also dissolve in fat pretty well. And so part of the reason you get drunk is, yeah, our liver can't quite handle it, but it can also get a little bit of alcohol straight in without it being treated by the liver. So if you're in my 112 class, I talked very early on about how you should be more worried about fat-soluble things. This is another reason to be more worried about fat-soluble things, because if you take the lacteal in, you can get in without going to the liver first. Here's just a little bit more close-up picture of that lacteal. You don't need to, did I cross it off on your sheet?
Yeah.
Good, okay. You don't need to pick it out. You might see it, but it'll take you too long to really take it out. Just take a look at this. This is what it will look like if you do see it. So here's your columnar epithelium. Really few goblet cells in this picture, but you will see goblet cells in the small intestine. But that lacteal is just this really thin, relatively flexible walled vessel that fat can travel across and then get into circulation. There you can see the goblet cells a little more. Get back to this one. So over here, all the white spots in the picture on the left-hand side. So you will see goblet cells all over the place. Remember, the goblet cells are just modified columnar epithelial cells, those little white spots there, all along here. The only thing that goblet cells help you for in terms of, functionally, they're for lubricating the food. Because you're starting to extract water now from your food in the middle of the small intestine, and as you move on, you're trying to recover all that water you've used for digestion, because if you don't, that's diarrhea, and the main issue with that is dehydration. So when you're subtracting water, you got to add some mucus in there so things keep moving. The further you get down the digestive tract, the more and more goblet cells there are. So that's one thing that you can pay attention to when trying to figure out where you are in the digestive tract. If there's a ton of goblet cells, you're probably not in the duodenum. Because like what we've been looking at here, like this would be an example, probably the duodenum, because there's not even that many goblet cells. As you move down further, like this one, over here, that's solid, just almost nothing but white spots. Those are all goblet cells. And so this is not something you would see in the proximal region of the digestive system. This means whatever's in here needs a lot of lubrication. So let me go back to the key distinguishing feature of the duodenum, which are Brunner's glands. That's illustrated in this picture. They're submucosal glands. They're secreted only in the duodenum. So if you see Brunner's glands, you know you're in the duodenum, and it's as simple as that. There's a ton of them usually. And these are really important for what we understand as buffering. So you're dumping acid inside of the stomach is just emptying into the duodenum. So you need something to buffer everything out. So there's a lot of bicarbonate secreted. In addition to what the pancreas secretes a little bit of bicarbonate, and these guys do a lot. And that's their main role. They're also thought to aid in protein digestion by secreting some type of enzymes, but for the most part it's understood as a chemical role to buffer out pH. And then this is the second distinguishing feature, not of the duodenum though. So if you see these, you're not in the duodenum. If you see Peyer's patches, you're actually most likely in the ileum, but you can find them in the jejunum too. So really, when you're looking at the small intestine, once you've decided that, you should be on a hunt for Brunner's glands or Peyer's patches. If you find Peyer's patches, you know you're either in the ileum or the jejunum. If you find Brunner's glands, you know you're in the duodenum. And that's pretty much it. Yeah, there'll be more goblet cells here. That's something you can note in the back of your head. But those are the key distinguishing features for making your decision for the small intestine. And these are, just explain what these are. These are just lymph nodes, basically. They're submucosal / transmucosal. They'll actually bleed across. They kind of look like some kind of growth that shouldn't be there. But these are these normal like follicles that you see that we looked at when we looked at lymph nodes. They're just called Peyer's patches, but they function for the immune system. That's where it's hanging out, waiting for something to try to come across the digestive membrane. That's why, like when we talked about blood groups, why it mattered if you had eaten tissue before. So you talked about like we assume exposure for A and B type antigens. This is why. Because if you ate something with an A or B type antigen, your immune system will be exposed to it, even if it never hit your blood. And so this is why eating is actually an important thing. Diversity of eating helps your immune system potentially too, because it's a way to expose yourself to something where it doesn't actually ever have to enter your blood whatsoever. So that's why you basically just assume exposure for anything with A and B type antigens, because almost all mammals have those. So if you've ever eaten any part of a mammal, you've been exposed to it probably. All right, on to the large intestine. Our last major region. Large intestine has a lot of parts. So large intestine is the most general term. So if you want to be really general, like you probably will want to be at first when learning about this, large intestine is what you're going to say, but large intestine actually has a lot of different subdivisions. The cecum, the appendix, the colon, the rectum, and the anal canal. The cecum, those are sort of written in order, but not, well, I guess they're kind of. So here's the only discrepancy in the ordering. It's kind of hard to order these ones. Here's the appendix. Here's the cecum. And so the ileum empties into the cecum, and there's an ileocecal valve right there. It's a passive valve. It doesn't really have any smooth muscle. And so it just prevents things from moving from here into the ileum. That's not a good thing. There's actually, this division here is quite important, because here in the ileum you don't have much bacteria that you want to keep. Any bacteria in your small intestine you fight and you kill. When it moves into the large intestine, this is where we have our native flora, right? Our bacteria that just lives there and hangs out and helps us with some things. If it gets out of control, it can hurt us. But for the most part, it's a good thing, and that division is actually quite important. So again, it's that ileocecal valve that is that doorway between small and large intestine. Then the appendix down here, this was categorized as part of the lymphatic system, even though it's connected to the digestive system, because this is full of basically Peyer's patches. When you look at it under a microscope, it's like nothing but Peyer's patches. So it's clearly immune system in some way. The jury's still somewhat out as to exactly this function. It's definitely not worth just pulling them out for fun anymore. They already decided that about 10 years ago. But if they get inflamed and can spread an infection, they'll remove them. But now it's a little bit more conservative with this because there's a thought that they play some role in maintaining the population of bacteria in your large intestine. I told you guys a story, for those of you who were in last term, I told you about the gum chewing story. My wife's friend who ate 32 sticks of gum.
No.
And tell you guys this? Oh, good.
Ate them, swallowed
She didn't eat them, sorry. Yes, well, it depends on, I'll tell you the story and you can decide if it counts as eating or not. It was when Trident came out with all the like cake flavored stuff. Like really dessert fiends were just all over it because you could just eat, key lime pie all day. And so I think it was key lime pie. And so she would just chew sticks of gum just all day, and she chews them constantly. And it has artificial sweetener in it, right? You don't want to have true sugar in your gum because that sugar is just going to deposit on your teeth. Bacteria is going to eat the sugar, eat away your teeth. So you use xylitol or other types of basically 0-calorie sweeteners that the bacteria in your mouth can't eat and you can't absorb. But the bacteria in your digestive tract can. That's why you don't drink the mouthwash. It's not because of the alcohol. It's because the sugar that they use to flavor it is not sugar in terms of glucose. They use some other kind of non-edible sugar, and it's not because it'll kill you. It's because if it gets here, the bacteria can digest it, and they produce gas as a byproduct. And they'll produce it so quickly that it will expand your large intestine to the point where you'll have to go to the emergency room. So that's exactly what happened to my wife's friend. She rushed to the emergency room with excruciating abdominal pain. They admitted her immediately. She was in pain, sweating, horrible, looked maybe like appendicitis or something like that. But her abdomen, she's a thin gal, and her abdomen was really large, which still doesn't necessarily mean it's gum. But they had actually recently had an article in the American Journal of Medicine that warned emergency room clinical staff that there has been a recent outbreak in people eating chewing more than 25 sticks of this particular type of gum, not that flavor, but like this new type of dessert flavored gum, because they would come in and they'd have these crazy pains and they'd assume it was something more serious. Turns out it's just gas. And it's just crazy how much gas though. So the clinicians really didn't think it was gas because of how big she was in terms of the gas, like they hadn't seen it before. And so that's the warning. Just because it's 0-calorie doesn't mean the bacteria can't get to it. And so you do have to worry a little bit about that. But cecum, I want to clarify the division between the cecum and where the cecum ends is kind of arbitrary. And so I'm going to pick very general structures or very extreme ends of things. So appendix is really easy to pick out. It's this little rat tail hanging off of the end. Some people it's way bigger. There's a lot of variation in the size, but it's way smaller than what you're seeing in the large intestine. For the cecum, it's basically, these are called haustra, these little bumps here. The plural is haustra, the singular is haustrum. There are about 4 or 5 of those in the cecum. That's about how big it is, just to give you a rough estimate. But if I ask you about this, I'm always going to ask at this extreme end. So don't be totally concerned at exactly when the cecum ends. And the next region is called the ascending colon, and when that one begins. Don't be too concerned about that. I'll pick it right by where the ileum comes in. You should think of the cecum as just what connects to the ileum. So let's talk about the colon, because this is something that I need to be very clear about what the difference between the colon and the large intestine is. So the large intestine is a more general term. So when someone has a colonoscopy or something like that, they're looking specifically at the colon. So the colon is everything after the cecum, so beginning right around here, and before you get into the rectum, right here. And there are 4 regions of the colon. 3 of the names make pretty obvious sense. And one of them is sigmoid, which means S, which once you realize that, also kind of makes sense. So you go from the cecum, you ascend, so the direction, they're named by the direction of movement of food. So it's going to come out of the small intestine, go into the cecum, go up the ascending colon. It's going to take an anatomical left-hand turn in the hepatic flexure. A hepatic, just because this is the side that your liver is on. It's going to go across the transverse colon to the splenic flexure, which is where the spleen is over here. That's where it gets its name. Then it's going to come down the descending colon, just goes down. And then the sigmoid colon, this is the S-shaped one. The issue with this and the models is there's a lot more depth than what's being illustrated here. This region is actually going deep into the person. And so if you think about this in yourself, the sigmoid colon, left-hand side, that's where you tend to feel gas moving. And now that I've said this, you might notice this, that when like about maybe a minute or two before you fart, you'll feel it in the sigmoid colon on your left-hand side, because that's right before it kind of exits. And so you'll feel that over here, but the sigmoid colon is not very deep. It has to get all the way back to your anus. And so it dives back really way deeper than I think a lot of people think when they look at this picture and what you see in the model. So just realize it's not like its sigmoid just drops straight down and comes straight out of the person, because then your anus wouldn't be where it is. It's got to go pretty far back. So sigmoid colon, a lot of dry fecal matter here and a lot of gas. Yeah.
Where does, if you hold it in, where does it go?
So that, it doesn't go anywhere. So,
But like the need to fart kind of goes away.
so yeah, so you have it, so as we move down from sigmoid colon into the rectum, then the anal canal. There's going to be a picture in a second that shows that you have a lot of layers of both voluntary and involuntary muscle in your anal canal. The internal, there's two sphincters actually. There's an internal anal sphincter and an external anal sphincter. The internal one is not controlled by you consciously. The external one is, though. And so when you're preventing an accident from happening, potentially, you only have voluntary control over the external one. And that works to some extent. But once the internal one gives up, that external one's got to work a lot harder. And so if you have any damage to the nervous system control of the voluntary muscles of the anal canal, you're going to have these kinds of fecal incontinence issues. And so as far as farting, it's gas, that's not solid. And so you can compress a gas. And so you compress it. And then, so ask Troy Jesse about the reasonableness, how reasonable this sounds from a bacterial perspective. But if you have bacteria living in a closed chamber like your large intestine, and you compress the bacteria have a harder time producing gas because the pressure's higher. So just like water, if the pressure's higher, water doesn't boil as soon. It's harder to get it to turn to a gas. The idea is that by increasing your intra-abdominal pressure, you slow down the gas production. You can't do it forever, so it doesn't work long term. But the other anecdotal support for that idea is what happens when people get on planes a lot. So if you get on planes, people run in, they have an incredible ventilation system on planes because people fart like twice as often when they're at low pressure than they do at high pressure. I'm not joking. Next time you're on a plane, pay attention. On your way up, it's a lot worse than on your way down because you get up to about 6,000 feet elevation in most planes. The new ones, they don't actually go that high anymore, but it's as if you're about a mile high. And so in that transition, the pressure lowers in your intra-abdominal cavity, and all of a sudden the bacteria are just flowing, throwing gas out there. But on the way down, the opposite happens. So that's the idea. I don't know how true that is, but it makes sense like from a very chemical and physical point of view. But I don't know how responsive bacteria actually are to pressure. All right, the other weird, hardest, well, no, the spelling's actually not that hard, but it always is annoying for most students. Tiene coli. There's an extra letter in that word. I don't really care how you spell that one. I do want you to be able to pick it out, though. So, in this picture, it was labeled in the other one, but this gives you a better picture of how it looks as a whole. It's this little, like, almost ribbon-like strip of mostly smooth muscle that runs, and there's actually 3 of them. In this picture, you can only see 2. Because one of them is on basically the front, the other one's on sort of the back side on this side, and the other one's on the back on the other side. So there are 3 of them, and they're evenly spaced around the cylinder that is your colon. And they work for assisting shortening and allowing for elongation of the colon on all sides, and they'll also assist in peristalsis, which is just that coordinated contraction of a tube in order to push something down it. Your colon is really crappy at peristalsis because it doesn't have much muscle. All it has are the TNA coli. But you can see it running here. It kind of goes away because it's on the backside now, but the other one is exposed here. And it runs the entire length all the way through the sigmoid colon and then stops. And so that's kind of a weird one, but it's a pretty important one because if you didn't have that, your colon would just be this sac that can't help things, can't really assist with things moving through it. You'd have to push it with your hands. You wouldn't be able to have your own body do it. Epiplotic appendages, these little fat chunks hanging off. We're starting to learn a lot more about what fat does. It used to be thought, oh, it's cushioning and nutrients, that's it. But there's a lot known now about leptin, fat being released and inhibiting your sensation of eating. These ones are suspected to help regulate the environment within your colon. So there's a lot of people trying to look into what these do because they're very weird. They're really variable between people. And they're like a third class of, or I guess a second class of intra-abdominal fat. In addition to the omentum, you also have epiplotic appendages. All right, so here's this picture of the anal canal. So here's where we transition back towards stratified squamous epithelium. And then you've got internal and external anal sphincters helping to keep everything closed. You actually have anal sinuses in here. You have hemorrhoidal veins, so this is one of the causes of hemorrhoids, is a change in intra-abdominal pressure that stretches out some of the veins that are around here. And these sinuses are actually the reason you can like fart without pooping, is that they actually hold the fecal matter in and allow that to happen. So anal structure is pretty important, and it is like the esophagus, as we age, it tends to not function quite as well. That's all I wanted to talk about with the anal canal. Here's what the large intestine looks like. More goblet cells here than you'll see anywhere else, mostly because things are really dried out here. This is where you're mostly absorbing water. The bacteria, the only other thing that they've been heavily studied is we absorb vitamin A across the lining of the large intestine because the bacteria make it as a byproduct of their metabolism. But that goblet cells everywhere. Also no villi.
What do the crypts of Lieber do?
You have to spell it with the umlaut and everything. No, they are the intestinal crypts. They are just, let me go back to this picture of the villi there. So, villi, pretty easy to see. Finger-like projections. These were only in the small intestine. Large intestine, it's like you just mowed them all down. There's no more villi. But there also are what are called crypts, intestinal crypts. And so these are like holes dug in the ground, not like trees emerging from the ground. But as you could imagine, when you zoom out, it looks like maybe this is just all one. But in reality, you kind of have to draw a line when you're in the small intestine. It's like a line that represents sort of the ground level, and the crypts are below ground level, and the villi are above ground level. In the large intestine, it becomes very obvious where the crypts are because there are no villi. And so let's go back to that picture and you'll see, now that you know there are no villi in the large intestine, then that little crack there must be your intestinal crypt. So this one's cut kind of funny, but there's one right there. Probably a portion of one there. There's another one right there. Another one right there. So they actually look a little bit more similar to what you see in the stomach with those gastric glands. But no villi, you don't need surface area here. This is mostly for reabsorption and bacterial culturing. So all you're left with are crypts of Lieberkühn, also known as intestinal crypts.
So, where are the runs of like darker cells in between the goblets?
So they are really just the basement membrane of the, so that's the nucleus of the columnar cells.
Right.
And then you will still have quite a bit of blood flow through here because you got to move the water out. Here's a little bit more zoomed out look. So again, it's part of the alimentary canal, so it's got the muscularis mucosae next to it. It's got your mucosal layer, just no more villi and lots of goblet cells. And then there's a picture in here of the anal canal, but we don't have that on your histology list, but it is where it transitions back to stratified squamous epithelium. All right, so the last thing we're going to talk about are accessory organs. I've eliminated the liver completely from the histology. We'll talk about lobes at the end. Well, let's talk about salivary glands real quick. I do want you to tell me salivary gland. I want you to be able to know when you're looking at a salivary gland. You do not need to distinguish between parotid, submandibular, and sublingual. So when we look at this picture, I could ask you to identify a duct. And a duct, by definition, a duct is a tube that is lined with either cuboidal or columnar epithelium. You'll see both in salivary glands. Here's one of them here. So that would be a structure. So if I put an arrow on this and said name the structure, it'd just be a duct. Now, the majority of a salivary gland are made up of what are called acini, which is a Latin term for berry, like a raspberry. And that never made sense to me until I saw a parotid gland and a pancreas. They actually look very similar. When you pull them apart, they're like a bunch of raspberries stuck together with rubber cement or something like that. And so when you pull the organ apart, it doesn't come apart like the organ's not all the same in texture. There's these little berry-like things in them. So the name comes from its three-dimensional structure, not really its two-dimensional structure. But that's what all these are. Here is an acinus. Here's another acinus, another acinus, another acinus. They're multiple cells, and they're the things that are making, in this case, for this cell, a lot of mucus. So notice how much white there is in these acini. This is a submandibular salivary gland, which produces a lot of mucus. So from the histology, you can kind of deduce that. Oh, look at all the white. This thing probably secretes a lot of mucus. Again, I'm not going to have you make that decision in diagnosing like what you're looking at. All I want you to know is, hey, I see some acini, I see some nice ducts, so I must be looking at a salivary gland. As far as specific cells, there are mucus cells, which I already pointed out. All the white ones, or lighter. They won't always be so white. They'll be lighter than anything else. Serous demilunes mean watery half moons. Remember that water-soluble things stain a lot darker, so they're all the dark purple that you see as part of the acini. And in this one you can see they are kind of half moon shaped. And then I already mentioned the duct. So you got one cell, which is a mucus cell. Serous demilunes are not cells, they're multiple cells, so I'll refer to them as a structure in the question. And same with the duct. That's also a structure. All right, let's take a look at the liver. A lot to do with the liver. The liver is very, very important, as I've already talked about. So knowing the anatomy of the liver, this is going to come up a lot. A lot of pathology. So on our list we have hepatitis. So hepatitis, we think of like Hep C, Hep B, all that kind of stuff because of like the vaccines. But hepatitis is really any inflammation of the liver. It is commonly caused by bacteria, or by both bacteria and viruses. And so, but it's not confined. Hepatitis is a general term for inflammation of the liver. And then cirrhosis of the liver is really hardening. So I hope you guys are seeing kind of the common theme of that when you have chronic inflammation of any tissue in your body, you tend to lay down scar tissue. You give it a few shots at regenerating it as it was, but if it keeps happening, you're going to lay down scar tissue, and you're going to lose function. The scar tissue doesn't do anything but kind of fill up space and tie things together. So your liver, if you keep damaging it, either through trauma, either physical trauma or chemical trauma or viruses or cancers, you're going to often generate hardened areas that are basically scar tissue. We call that cirrhosis. That's different than fatty liver. For other reasons, cells in the liver will actually become basically fat, and that's not very hard, but it's not usually liver hardening either. But we have a left and right lobe. As long as you guys can tell left and right, you'll be okay with that. There are other lobes of the liver, but I don't believe you have them on your sheet. So I'm not telling you the whole story. There is also a caudate and a quadrate lobe, so if you encounter that in the future, don't act totally surprised. But they're harder to pick out visually, especially if you don't have a real liver. So for this week, just left and right lobes of the liver. And then you also have a falciform ligament and a round ligament that kind of divide the left and the right side of the liver, lobe of the liver. Falciform ligament and round ligament are remnants of fetal circulation. And so when you had blood coming in from the placenta, all oxygenated and ready to enter the fetus, it would come through and enter into the inferior vena cava. It would enter just superior to the liver. And so when that closes off, it actually creates a little ligament called the falciform ligament, and the top of it is called the round ligament, and this anchors the liver to the anterior portion of the abdominal cavity. So it helps it stay in place. The livers are heavy and big, so they really do need this kind of suspension. They're sort of hung within your body, and they're really heavy organs. They're a solid organ. There's no holes. There's not a lumen in here. It is a big, solid organ. All right, let's take a look at those ducts. I got a good picture that illustrates all the different ducts. So the reason this is connected to the liver, we're going to bring up the gallbladder here. Gallbladder, you need to know, exists. It is actually green. It's not just the coloring that the artist decided to throw in there. But the gallbladder is a storage area for what the liver makes. And so the liver, if you look on this side, the liver is actually connected to the gallbladder through a series of ducts. And so the connection from the liver to the gallbladder and then eventually to the small intestine begins with the left and the right hepatic ducts. These are coming directly from the liver. The left and the right hepatic duct merge together to form the common hepatic duct. And then the common hepatic duct merges with the cystic duct. Cystic refers to the gallbladder. Whenever you hear that word, think gallbladder. So cystic duct, common hepatic duct merge together to form the bile duct. And then that bile duct is what's going to continue. It's going to eventually merge with the pancreatic duct, and it's going to empty into your small intestine. And so what your liver is making and storing in the gallbladder are what are called bile salts, and these are really important for digesting fats. And so if you want to think of a function of the gallbladder, it's really for emulsifying fats, which means to make them mix easily into water. And so I mentioned that like egg yolks, raw egg yolks are really amazing emulsifiers. That's why you can get oils and waters to mix if you mix egg yolks into them. It's really cool. You have to stir them really fast, but you can do it. And your gallbladder kind of does that for you too. And so what it allows you to do is even if you go out and eat a super fatty meal, like just nothing but lard, don't do it. But if you do that, that fat is a huge blob that doesn't mix with water, and so what the gallbladder is going to do is secrete this emulsifier so that you can break that apart and increase the surface area on the fat and more efficiently break it down. And if you eat too much fat, you still won't break it all down, and it'll eventually make its way unbroken down into your large intestine where the bacteria will eat it and you'll have terrible gas. So this is one of the issues you have to worry about if you don't have a gallbladder anymore. It's not the end of the world. It won't kill you like it will if you lose your pancreas. But you do have to watch your fat intake. And if you have a dietitian can help you with eating foods that have natural emulsifiers in them that help you digest the oils. And so there are some strategies to help deal with the lack of a gallbladder. Or maybe just a gallbladder that doesn't work quite so well. So those are the ducts there. So take a look at that picture if you're trying to review that. I recommend drawing a little map for yourself. But just notice if it says hepatic in the name, it's only connected to the liver. So the fluid in this tube is always only from the liver because it's flowing downhill. And then the fluid from the cystic duct is coming from the gallbladder. And then once it gets the bile name, it's actually a combination of stuff from the liver and the gallbladder going out. So if we look at the pancreas here, just while we have it in front of us, it also has a duct called the pancreatic duct, and it also has an accessory pancreatic duct. Some people have this, some people don't. It's this one right here. And then you have these separate sections. You have our head, neck, body, tail. The divisions are kind of arbitrary, but that's the order that they go into from low left to top right as far as the divisions of the regions of the region of the pancreas. Pancreas is not really there for emulsification. Pancreas' main role is it's our essential organ for breaking down proteins. So if you don't have a pancreas, you can't break down proteins and you'll die. And that's why pancreatic cancer is such a devastating thing, is that unlike maybe cancer of the gallbladder or something like that, if you don't have a pancreas, you will starve, basically. Oh yeah, and you won't be able to manage your blood glucose, which will kill you even faster. And so your pancreas is such an important organ because it has not only digestive functions, breaking down proteins, but it also has endocrine functions in releasing insulin and glucagon and other hormones into your body which regulate blood glucose. And if blood glucose gets out of whack, you're not going to last very long. It's a very, very important organ. Let's see if I can. And then histology of the pancreas, you guys have actually already looked at, so I'm not going to talk about it. Let me just remind you of what you've already seen. The pancreas has acini, just like the salivary gland. So if you remember last time we looked at the pancreas, our key thing we were looking for were islets of Langerhans, or the pancreatic islets. That was your distinguishing feature, and it still is today. But I just want to warn you that salivary glands and the pancreas look a lot alike because they both have acini. So it is more important now than ever to be good at picking out the islets, because if you can pick out the islet, you know you're in the pancreas. It's as simple as that. But if you're not good at picking out the islets, they might be right in front of your face, but you might answer salivary gland. And so it really does hinge on this pancreatic islet ability to pick those things out. So I'd encourage you, when you study the histology of the pancreas, grab a couple salivary gland slides too and put one in front of your microscope, then put another one in another microscope and bounce between the two and get good at picking them apart, because that is an easy one to make a mistake on. All right, that is it for me today. All the models are in the back. I'll only ask you